Hi there. Believe I'm. Forgive me if I pronounce your name wrong. It's Layla. Um, I'm John. I'm recording this video for you on the review that you wanted for Restory. From your email, it said that you wanted to just go over what empyema was, emphysema, ARDS, pleural effusion, and pneumothorax. So I'll briefly touch on pretty much all of these and go over the major signs and symptoms. So hopefully when this video goes through, you can see what I'm writing down here, and you'll get a better understanding. So we have ARDS as our first topic that we can look at, which is acute respiratory distress syndrome. Mainly with ARDS, it's like an exacerbation, right? It's happening after acute respiratory failure happens. So acute respiratory failure is basically the body isn't able to oxygenate properly. Your lungs are breathing, but your organs, your extremities aren't being perfused correctly. So ARDS is a state in which you have respiratory failure. You have inflammation that is happening. Your alveoli are collapsing or they're filling up with fluid, and you're just having a general trouble breathing. So if I write that down here, you have failure of membranes to oxygenate, and then we can do that as a subsection. This is a progressive failure of acute respiratory failure. So when you're assessing someone that has respiratory distress failure, the most common causes, so if we go to causes of ARDS, we have sepsis, trauma, smoking, aspiration. You could do pulmonary embolism. I don't know how to spell that. So just think, to have somebody go into acute respiratory distress, they have to have a factor that is causing the body to consume too much oxygen, or there's something wrong with the lung to where the body isn't able to send, or where the lungs aren't able to send out enough oxygen. So if we go to our signs and symptoms of somebody with acute respiratory distress syndrome, they're obviously going to have trouble breathing, so we call that it's dyspnea or dyspnea, or some people would say. You're going to have a little bit of cyanosis. You're hypoxic, hypoxemia, and this is basically their SpO2 level is going to be less than 90%. In people with chronic COPD, you'll see that their values are like 85, like not even 85. It can go lower than that. You could say like lower 80s, like 83% to 87. That's with people with COPD or like chronic lung issues. They'll sit around that level. What else could we see? We could see restlessness. And that's because they're not oxygenated. You don't have enough oxygen in your body starts fighting for more stuff, and you're gonna be fidgety and antsy. You're gonna try, you're gonna be annoyed that you can't breathe. And to compensate with not being able to breathe, here you're going to have tachycardia. So those are your main signs and symptoms. If we want to have a diagnostic test, so diagnostic test. Your standard is going to be ABG, and you're going to monitor for like a respiratory acidosis usually, I believe, with this one. ABG. Yeah, so more or less you're going to monitor for respiratory acidosis. Yep. Okay. Where are we at now? Okay. Sorry, I'm going through the textbook here. I'm trying to see what I can write down to help better explain it. All right, let's just go straight to treatment here. So treatment obviously is going to be, there's going to be some sort of medication involved. You're going to have, you can use benzos. You can use benzos to stop the anxiety. So this is to reduce the restlessness. Also, if they're less restless, their body isn't demanding as much oxygen, so this can increase a bit of the perfusion going through. In a person that is in severe distress and they're intubated, we're going to have anesthesia. With anesthesia, the most common one, if they're ventilated, is going to be propofol. Normally they might have other drugs called Precedex, or they might do Versed, sometimes ketamine, with people with respiratory failure. And this is, they have a tube down their throat. You don't want them freaking out, and if they pull the tube out, it's going to be traumatic to the upper respiratory, their larynx, their trachea, all that stuff. And then obviously they're not going to be able to breathe because they have a tube in their, they took their breathing tube out. Corticosteroids. And if you're in pharm, I believe you should have already reviewed corticosteroids. This is obviously to reduce the inflammation. I'm sorry, my spelling is so bad. Inflammation. And then pain medicine. So pain meds, and you're going to be primarily looking at opioids. So fentanyl, morphine, Dilaudid. Pain is coming since they're not oxygenating. There can be hypoxemia. There can be some level of ischemia that's happening, and it's very painful. If your body isn't receiving oxygen, tissue is dying, and that's going to be painful. And then the book does say something about neuromuscular agents like a paralytic, but I don't think Dr. Allen is going to ask you about what paralytic you're going to give, because it's not really relevant to your scope of practice as a nurse right now. But antibiotics is probably going to be a big one here as well, because if there's an underlying infection, like if they have pneumonia or they have just like pus or something building up in their lung, then we're going to want to treat that. We want to get rid of the infection. That way we can increase the body's oxygen demand. Let's see. So, yeah. This is primarily what you would need to know about acute respiratory distress syndrome. There are some complications with this disease. I'll just write them over here quickly. So if we're looking at complication, we're going to aspiration, pneumonia, infection, endotracheal tube, yeah, I mean, that's primarily what you would need to know. Yeah, okay. So, I did ARDS first because the other couple ones that you had asked can all be put together. I'm gonna come down here to a fresh page for you. So we can do pneumothorax. We can do empyema, and then we can do pleural effusions together. All right. So the basic idea, or the what's it called? The whole overarching topic, right? So how are the lungs set up? So you have this here. Forgive my drawing. You have janky chest. This is a neck, by the way. You have your, let's say here, and you have your lung stem that branches off right here into your lung, right? Let's do this, and then obviously you'd have your heart somewhere here in the middle. This entire area that I'm putting these little, let's use color, this yellow highlight in, this is all open space. So think of it this way: open space. The lungs need open space to expand, right? The lungs are like a balloon. If the balloon doesn't have space to expand, then it's stuck there. And oxygen is exchanged at the bases of the lung here. So like here's where your like alveoli and things are, like in the bases of your lung. If the oxygen isn't able to perfuse to those areas, then your body is not perfusing correctly. So a pneumothorax is basically when one of the lungs collapses. All right, the lung goes small, and so air from like inside of the lung starts leaking outside into this area. And when air leaks into the area around, so that's into your thoracic cavity, the air starts to becomes a pressured environment, and then it starts to squeeze down on the lungs, and all of this right here becomes filled with air, and then the lung isn't able to expand. And empyema is when, I'm going to come to the other side of the lung here, is when in the pleural space, so that area around the pleural space is not able to expand due to an infection. So here, like in outside, there's like a little sack of pus that's gonna build up, and that's what an empyema is. And you now have an infectious process inside of your lung, and that's dangerous, not only because it's an infection, it's also pressing up against the lung. It's not allowing your lung to expand all the way. A pleural effusion is, instead of pus being built up, you have water or fluid buildup, and it would be in the pleural space, so you have fluid buildup outside of the lung, usually toward the bases, and then if it's severe, you'll have water or fluid that'll build up all the way around outside, forcing this lung to collapse. So that's the general gist of all three of those. Now, if we're going to like signs and symptoms of what a person is having with an empyema, a pleural effusion, or a pneumothorax, pretty much all of them are going to be the same. You're going to have let's go here, signs and symptoms. You're going to have respiratory distress, so that's increased heart rate, so tachycardia, increased heart rate. You're going to have increased breathing, so increased respiratory rate. They're going to have use of your accessory muscles. So I don't know if Dr. Allen has covered that yet. When someone is breathing really hard, since I'm gonna just do this here. Like here, you have your ribs, right, along the side. You have muscles that connect in between the ribs. Now, on normal expansion, you are going to have an equal rise in the chest, but with increased respiratory rate from here in the bases, you're going to use your muscles a lot more harder, and you'll see a person. I can't show it to you, but when they breathe in really deep, you'll see the sides of their chest expand out more than normal. With your what's it called? Hypoxia. There it is. That's the word. Hypoxia. And then cyanosis, since they're not perfusing all the way. If we look at some specific things, so for pneumothorax, since one of the lungs has popped, you're going to have absent lung sounds on the side that the lung is collapsed, and usually this is treated with a chest tube, or they'll do a bedside needle decompression. With either pleural effusion, let's see, like with either pleural effusion or empyema, PYEMA, you'll end up having like crackles, coarse lung sounds. You could probably maybe see some expiratory wheezing, but I don't think so. Normally with these, we're also going to be using a chest tube. So the chest tube would be placed at the base of the lungs, and this would drain the fluid out. We could also do antibiotics, especially for this empyema, to treat the infection. You could also do something called a thoracentesis, and that is basically what a chest tube is. They're going to cut a hole in the side of the lung, they're going to place the tube, and they're going to drain everything out. We're going to do a chest x-ray to let's see, diagnostic. We're going to do chest x-ray, so CXR, or we'll do thoracentesis, which is basically chest tube. Medications, I really can't give you an accurate, like one size fits all. You can generally, you're going to be in pain, so pain meds, something for anxiety. Could also do diuretics for pleural effusion, because there's fluid, and we're going to try and diurese all that fluid off. Antibiotics for the empyema. Yeah. If they get intubated, you're going to want to monitor their ABGs. So I guess we could throw ABGs in here as well. But that's the primary breakdown for most of that disease. And the last one that you had was emphysema. I don't have much to say on emphysema. What I can tell you, it's an exacerbation of COPD. So you have COPD, and basically this is a subsection SCC subsection. It's like COPD is the overarching disease, and then emphysema is like a small part of it. I don't I don't necessarily know how to explain it. Let me just look it up and see what the actual definition is, because it should be all the same signs and symptoms. You know, you're gonna have trouble breathing, you're going to have cough, you're going to have increased heart rate, clubbing of the fingers, poor oxygenation on exercise, barrel chest. Barrel chest is like when your chest rounds out from sitting forward and breathing too much. Wheezing, sputum production. It's all the same thing as COPD. So I believe you should be fine in there. If the recording that I isn't clear on that, then if you have a specific question about it, then you email it to me. I can answer you better. If anything in this recording didn't make sense, I really encourage you to have a specific question in mind, and I can better guide you toward an answer. But this is just the general overview of everything. I'm going to post this video to YouTube, and I'll send you the link, and then I'll also post this actual document that I did all the writing on in the email as well when I send it back. I wish you good